So I'd be quick now. So I'd be focusing only on the part on pediatric ALF because most of this has already been talked about by Dr. Raki, and I would avoid repetitions. So among the various extracorporeal liver support system which are classified as artificial and bioartificial obviously provide an extra benefit that they provide the functional capacity of the liver, which is not provided by artificial liver support. But among the artificial liver support, the data in pediatric mainly comes from TPE, CRRT and MARS, and so I'd be concentrating on these three. The most of the data in pediatrics come from therapeutic plasma exchange. The mechanism has already been well explained by Dr. Raki, so I'd skip that. Now on the basis of the various adult RCTs and studies, ESL recommends therapeutic plasma exchange. Definition here is biochemical evidence of acute liver dysfunction, which is with coagulopathy. Now only difference is from adult is coagulopathy we are saying INR more than 2 even in absence of HE can be ALF, and INR more than 1.5 with HE. So that is the only difference, rest all is similar to the adult. So HE is not mandatory. Yeah. So the ESL recommendation and American Society of Apheresis clearly tells that TPE is recommended in ALF and there is greater benefits if it is started early. But what these recommendations fail to tell is how do you select which patient. Reading this recommendation, I talked to some of my colleagues and they feel like, colleagues from outside the institution, and they feel like every ALF should undergo TP. So the question that remain in our mind despite these recommendations are, is there enough pediatric evidence to recommend TP in PALF? If yes, then among PALF, who should be offered TP? Universal all ALF or selective patients? If offered, what volume, what frequency, what number of sessions? And the most important question is, how do you decide about timing of LT once you have put the child on TP, because all your parameters will be artificially modulated by it. So coming to the first part, is there any evidence to support TP in pediatric acute liver failure? One thing is clear, that the safety has been shown in most of the studies, and the native liver survival in most of the studies range from around 50% to 60 to 75. So about half to 3/4 patient can survive with native liver even among those who are meeting the respective transplant criteria or are having advanced liver failure as evidenced by INR more than 2 or bilirubin more than 17 or meeting the respective transplant criteria. Specifically, if you can see from our study, among Wilson disease, this is one etiology where TP seems to be showing a greater response as compared to other etiology, and this has also been confirmed in studies from other centers where patients were predominantly Wilson disease ALF, the response to TP was better. Coming to one of our paper which is under revision right now, the revision has been submitted, where we are comparing the TP versus no TP by using a propensity score matching, and we can see here that normally we would expect a bias from the investigator and as well as from the patient, that the most sicker patients would offer TP and the most sicker patients would accept TP. So that is why if you see the whole cohort of around 403 patients, among which we have selected 354. So if you see the whole cohort, the sicker patients, that is those with grade 3 to 4 HE, those with higher INR, those with higher bilirubin and those with higher ammonia are likely to be offered and accept TP, whereas those not getting TP are usually a milder patient. So you cannot compare these two groups. So we took a propensity score matching on the basis of factors which affect our decision of TP like INR and HE, and the factors which are independent predictors of outcome like bilirubin and ammonia. And now you can see these two comparable cohorts of 65 each. They are a cohort of very sick patients, that is 80% of both the groups are having grade 3 to 4 HE, 80% are on mechanical ventilation, and mean INR is around 4.5 in both the groups. And when we compare the outcome, we can see that the native liver survival is 46% versus 26% in a sick cohort of very sick cohort of PALS patients comprising more than 80% with grade 3 to 4 HE, and overall survival is 50% versus 40% in the two groups. Importantly, among the patients, the time to event, among the patients who did not survive with native liver, the time to event was significantly higher in TPE group, that is 7 days versus 5 days. So we are getting 2 extra days to arrange for a liver or to get a liver if it is in deceased donor liver setting. So it gives extra 2 days for your therapy to work or for a liver to be arranged or a donor to be arranged in that time point. So it can act both as a bridge to native liver survival as well as a bridge to liver transplantation. Importantly, on subgroup analysis, we can see that this effect was predominantly seen in hepatitis A related PALS, which is the commonest cause of acute liver failure in Indian setting, and this benefit was not present in other etiology of pediatric acute liver failure. As expected, we can see that by day 4 in the TPE group there was a better map, so improved hemodynamics, lower INR and a lower bilirubin and lower ammonia. This difference was not there at day 7, but this could be because the numbers on day 7 in control group was low because of the high mortality in the control group. And on regression analysis, we can see that apart from the usual suspect, that is INR, JE interval and HE grade 3 and 4, the TPE group was another independent predictor of native liver survival. So, on the basis of recent evidence that is coming up in pediatric acute liver failure from our center as well as from other centers, safety is very well established, efficacy possibly yes, but we need RCTs, we can to say it more firmly. Now, the next most important question in my mind is, if we have to offer PALF, how do we offer, to which patient we offer PALF? So, I have put here 3 case scenarios, and if you can quickly go through them and tell me where would you offer. If you go by ECL guidelines, you will offer to all 3 of them. All 3 are ALF, all 3 have HE, all 3 have INR more than 2.5, all 3 have HE 2, 3. So, whom would you offer? Anyone wants to say quickly? First, second one, but his bilirubin is much higher, 19, INR is 3. This also. And third one, so you will offer to all 3. Okay, if I have to say, anyone wants to ask any other question before deciding whom to offer TP in these 3 cases? There is no right and wrong answer, and it could be everyone's view. So anyone wants to ask some more question? Okay, let's see. So the first question that would come in my mind, I would want to see the response at 6 to 8 hours. And if you see, let's see one by one. Case 1, HE grade 2, INR 2.8. Now at 6 to 8 hours, his INR becomes 3.41, HE progresses to grade 3. I would most likely offer TPA to this patient. Yes. Now coming to case 2, this patient had HE grade 2, INR 3, but by 6 to 8 hours, INR had become 2.61, HE had remained at grade 2. I may want to wait in him and see what is happening. Yes. And if you see case 3, at admission, this patient also had AKI grade 3, was on 2 inotropes and high ventilatory settings, and by 6 to 8 hours, his INR had further increased. Now, this patient, I may feel that he is unlikely to benefit by this, and is possibly not reversible, and I may not offer TPE to him. So, what are the factors that we are taking into consideration? Mainly, we are taking reversibility, whether the native liver can recover or not, the trend of INR and the trend of HE, to suggest that whether the patient is going downhill or uphill. Now, sir, yeah, I am coming to the timeline, sir. Sorry? JE interval, I would skip the JE interval, because I don't think that can be an independent decision for TP or no TP. By 6 to 8 hours, decision has to be taken on day 1, because early TP. I would a bit disagree with that, and let's go ahead and see further. So, if you see the natural course of pediatric acute liver failure, once there is an acute event, the liver reserve goes down. This is the threshold for liver failure, and the patient and the liver reserve can go up and patient can survive. The second outcome can be that the liver reserve continues to goes down and patient dies. The third outcome can be the patient was improving, but then has an acute event like sepsis or bleed and he dies. So, these are the 3 possible natural course that we see in pediatric acute liver failure. So, what is day 0 for you may not be this time point. The patient can come to you here, the patient can come to you here, the patient can come to you here, and you don't know at day 0 at 0 hour that where is the patient, and that is, I think, is the crux, because at time, if suppose the patient comes to your T1 or T2 time point, at this time point he is likely to have very high levels of inflammatory cytokines and very low levels of regenerative growth factors. If the patient comes to you at time point T3, he is worsening, inflammatory cytokines have further increased, and regenerative growth factors have not come. But if your day 0, when the patient has come to you, is at T4, T5, at first INR you can never say where is the patient. If the patient is in T4, T5, his inflammatory cytokines have started to come down and regenerative growth factors have already appeared in a very good concentration. And if you do plasma exchange in this patient, as Dr. Rakhi has shown in her study, that the growth factors will all be washed out. So, you don't want to do a therapeutic plasma exchange to a patient who comes to you at T4 or T5. You will cause more harm than good. So, let us go back and see our cases. Case 2, I had shown that although he had a longer jaundice to HE interval, his INR was 3 and his INR decreased to 2.6 by 6 to 8 hours and 2.49 by 12 hours, although HE remained at 2. So, I would like to believe that in current clinical scenario, when you cannot get the cytokines quickly within 6 to 8 hours, a clinical assessment based on a trend of INR will put this patient in somewhere between T4 and T5, and I would like to possibly avoid plasma exchange in this patient. Case number 3, jaundice, multiple organ failure. So, he is possibly in T3 and I would like to avoid this in view of futility of TPE. And case 1, where although it was a hyperacute liver failure with INR of only 2.8, but which was rapidly progressing and HE was progressing, this patient progressive INR, progressive HE, that means he is still in T1 or T2, and this patient I would actually put on TPE and is likely to benefit. So, on the basis of, and let us see how the cases of, how the studies have selected. The Larsen study selected ALF with grade 2 or more HE. Dr. Rakhi selected ALF with cerebral edema on CT and no donor for liver transplantation. Stahl selected all ALF, and this selected ALF on LT waitlist, this Korean study. More importantly, this was acetaminophen, viral hepatitis, toxin induced, and so on. So, the etiology is also important apart from the timeline, that is Wilson disease as shown in our study, toxin ingestion like APAP from Larsen study and rodenticide from CMC study, and viral hepatitis A as in Dr. Rakhi's study and in our data which I showed just now. So, these are the possible etiologies where TP is likely to work. So, what we follow at ILBS right now is a patient fulfilling the PALF definition with a rising INR or worsening HE after 6 to 12 hours is what we are following right now, and the proposed ISPAGAN recommendation 2024 is it can be considered as a bridge to native liver recovery or a bridge to LT in children with ALF fulfilling LT listing criteria, depending on LT listing criteria available or not. So, it may be considered, it is a strong recommendation if there is no LT option, or it is a weak recommendation if LT options are available, and there is a strong recommendation in Wilson disease or yellow phosphorus poisoning. So, yes, sicker patients should get who have possible reversible etiology. Ideal would be to measure cytokines, but in absence of that we can see the trend of INR and HE. What is the most suitable volume? Ashish has given me this slide which shows that if you exchange one time plasma volume, you exchange 63% of the patient's blood. The toxins, you clear the toxins, 63% of the toxins in the plasma. If you exchange 2 times plasma volume, you exchange 86%, 3 times you will exchange 95% and so on. So, this curve shows that extending beyond 2 times plasma volume, you are going to get little benefit, but at high cost. That is, you increase the load on plasma bank, complication, cost, and longer duration means more risk of infection.
Hold on to this very important slide. It shows you half volume removes 40%.
Yes, sir. Yes.
And therefore, it will remove 40% of the regenerative factors.
If the patient is at that time point.
Yeah, so it might be most sensible to use half volume or 1 volume. Do not remove, because you will remove 86% of the regenerative factors and also anti-inflammatory. So,
Timing of the
yeah, timing I don't know. I would say as early as possible.
Yes. So,
you will have lesser growth factor.
yes.
No,
Yes.
rebound, absolutely.
Yes.
Very good growth factor.
So, definitely more than 2 is a strict no, because that would be a very much cost. 1 versus 2, there is a recent study, okay, I'll come, there is a recent study 1 versus 2 times, but this is retrospective study coming from Asian Institute, and we show that it is comparable native liver survival. So, we do not know yet what is the correct volume, no specific answers, but definitely not beyond 2 times. Frequency and number of sessions, I would believe you should do it daily. If you do it alternate day, you will go until day 5, and your decision for LT and all those decisions will keep getting delayed if you do it alternate day, which was used by AIG group. And one study in pediatric has shown that if you go beyond 6, you are likely to cause more harm than good. Usually, everyone tends to restrict to 3 or even less than 3, as Dr. Raki just showed. The most difficult question is how do you decide about timing of LT? Once you put these patients, suppose like this patient, 13-year-old, INR more than 3.1, HE grade 3. So he fulfills Pete's HAV criteria. He may not fulfill the KCH criteria ever, so we don't go by that in HAV. So he fulfills Pete's HAV criteria for a liver transplant. He's listed and donor evaluation has been started by the time he gets first TP. Now the INR, which was 4.24, goes down to 1.9, and by 18 hours before day 2 TP, it bounces back to 3.3. Now we don't know what bounce is non-response and what bounce is response. So we cannot make a decision even if the donor is ready. So it is a controversial. You may decide to go for LT at this time point. You may decide to do another TP or a third TP. Now only after third TP in this case we are clear that the patient is going to make it with his native liver. But these decisions are very difficult. There is no way. Ma'am was talking about one model which she has worked on. We would obviously want to evaluate that model and see if that works to decide on day 1, day 2, day 3 that which patients are going to make it. So at present we are guided by trends in INR and ammonia, the rebounds. In future we have to use AI based models or a cytokine profile which can help us decide whether we should go ahead with further sessions of TP or not. This study from our liver transplant team has shown that in patients undergoing plasma exchange prior to liver transplant, there was better outcomes with regard to time to extubation. Now you can see that one thing is the patients who underwent plasma exchange were sicker patients. Almost 100% were grade 3 to 4 HE, whereas only 50% of patients not undergoing plasma exchange were grade 3 to 4 HE. And the time to LT obviously was higher in patients undergoing plasma exchange because the decision will be waiting for the response of TP. But what we see is the recipient outcomes, and we can see that the day of extubation was 2 days in plasma exchange group versus 6 days in patients who did not receive plasma exchange prior to liver transplant. Apart from this, there was one study from I think from the organ transplant anesthesia which showed that the inotrope requirements were lower and it could be stopped earlier, but I couldn't find that study. So these studies show that it may be beneficial to do plasma exchange even prior to LT as a bridge to LT. Coming to CRRT, the standard indications we all know, the non-standard, that is non-renal indications, as Dr. Raki said, are HE grade 3, 4 and hyperammonemia. We can do it in children as small as 8 to 20 kg, and recently we did it 2 to 3 days back in a child weighing 10 kg using HF20 filter, which can be used in children as small as 8 kg. And but problem is getting the lines, so 6.5 French line was put by Dr. Amar, and we could do TP as well as CRRT in this 10 kg child. So one more important thing, this study in dengue related PALF has shown that patients receiving TP plus CRRT do better than patients receiving CRRT alone. So a combination is feasible either in series or in parallel. What we do right now is we hold CRRT and do TP, but they can be done together either in series or in parallel. ILBS data we have not published and we have not sent this anywhere, but I just dug out the data on CRRT. So 80 patients with pediatric acute liver failure have received CRRT in our center. 36 received it late in the course for renal indications, and these 36 obviously had a poor outcome because this was just given as when the AKI came up. So only 8.3% native liver survival in the group when CRRT was instituted late. But when CRRT was instituted early, which we have now shifted to over the last 2 years or so, among those native liver survival was comparable, better than control, 45.5 versus 31.8, but not statistically significant. Overall survival was not statistically significant, but there was greater decline in ammonia. So as Dr. Raki said, the TP may provide survival benefit, but it may not reduce ammonia as much. So for ammonia and lactate, you may need to add CRRT along with that. So usually CRRT started early, and then if indicated, TP is added thereafter. So ISFAGAN latest recommendation, which CRRT should be performed in patients with PALF with persistent acidosis, dyselectrolytemia, fluid overload or persistent hyperammonemia. Then there is MARS, which has already been discussed. I will skip that, and so I will come to my summary and conclusion that TP, CRRT and MARS are the commonly used extracorporeal liver support system in PALS. TP is safe in children, well proven. Efficacy, possibly, just that there is no RCT, but there is no reason to believe why if it worked in adult will not work in children. How to select the patient? We select right now on progressive INR and HE. We need more studies on to decide on the volume, the protocols, and how to prognosticate while on TPE. CRRT, apart from renal indication, we should actually use it for non-renal indications in pediatric acute liver failure, that is hyperammonemia, hyperlactatemia, and fluid overload. And MARS is expensive and needs pediatric studies and usually not feasible in Indian setting. Thank you.